Welcome to this explainer. When we think about severe eating disorders, our minds usually jump straight to one specific narrative, right? It's almost always about body image. But medical science has formally recognized a parallel condition, one that looks exactly the same from the outside, but is driven by a completely different internal world. So today, we're breaking down the science, the symptoms, and the psychology to understand why treating these two distinct conditions as the same thing can be a critical, even life-threatening mistake. We're talking about ARFID versus anorexia nervosa.
Okay, let's quickly run through our roadmap for today's explainer. First, we'll cover identical symptoms, different disorders. Second, inside anorexia nervosa. Third, understanding ARFD. Fourth, the crucial psychological distinction. And finally, tailoring the treatment. Let's dive right in.
All right, part one, identical symptoms, different disorders. We're starting our journey by looking at the visible, physical evidence that these two conditions leave behind.
I want you to imagine a kind of medical detective scenario where the clues point to a severe crisis, but the underlying suspect is an absolute mystery. Say a patient presents at a clinic with extreme weight loss, severe malnutrition, and failing organs. Now, for decades, the medical community itself historically misjudged this. They assumed these undeniable physical signs universally pointed to one single psychiatric diagnosis. But as we're going to see, surface-level symptoms just don't always tell the whole story, which is exactly why recent diagnostic updates have been absolutely vital for getting patients the proper care.
Think about the severe medical consequences both conditions share. Whether it's driven by anorexia or ARFID, the body's physiological response to starvation is literally identical. The body essentially goes into full-on survival mode, shutting down non-essential functions just to preserve the brain and the heart. That's why we see dangerously low body temperatures, severe electrolyte imbalances, and bradycardia, which is a dangerously slow heart rate. We also see anemia, weakened bones, and in younger patients, delayed puberty or a failure to hit expected growth milestones. The physical stakes are incredibly high across the board, and the initial medical stabilization required to save a life, it's virtually indistinguishable. Moving to part two, inside anorexia nervosa. Let's peel back that first layer by looking at the condition we traditionally expect to cause these severe physical symptoms.
So the absolutely crucial point for anorexia nervosa is that the malnutrition is directly driven by an intense fear of gaining weight and a fundamental disturbance in how the person experiences their own body shape. As outlined in the core diagnostic criteria, this isn't just about eating less. It is an active restriction of energy intake fueled by a relentless psychological drive. The individual's entire self-evaluation becomes intensely intertwined with their shape and weight. And tragically, even when they are at a significantly low weights, they often fail to recognize the severe medical danger they're in, because, well, the mirror is essentially lying to them.
Okay, part three, understanding ARFID. So what actually happens when the exact same physical starvation occurs, but without a single concern about body image or weight? This is where our medical detective story takes a really fascinating turn.
Enter ARFI, the invisible twin. This diagnosis emerged in the DSM-5 and completely upends our assumptions about why dangerous food restriction happens in the first place. ARFI stands for Avoidance/Restrictive Food Intake Disorder. Now notice the absolute key phrase defining this condition. It is driven by reasons unrelated to body weight or shape concerns. A patient with ARFID might be just as malnourished as a patient with severe anorexia, but if you ask them about their body image, they likely have a completely neutral or perfectly accurate perception of it. They do not have a drive for thinness. They simply cannot eat enough to sustain themselves.
ARFID is actually driven by one, or sometimes a combination, of three distinct pathways. You've got sensory overwhelm, terrifying condition fears, or just a profound lack of interest in food. Imagine the texture or smell of a certain food triggering an overwhelming physical panic. That is sensory avoidance. Or picture a child who choked on a piece of meat and is now completely terrified to swallow solid food, leading to an extreme fear of aversive consequences. Finally, there's a chronic physiological lack of interest or low appetite. The fundamental desire to eat is simply completely absent from their daily experience. The American Psychiatric Association notes that the health impact of ARFID can be as severe as an anorexia nervosa, and in severe cases, particularly with infants, the malnutrition can absolutely be life-threatening. This brilliantly illustrates why ARFID must be taken just as seriously. It is not just picky eating, right? Because ARFID lacks the intense body image distortion of anorexia, it's far too often dismissed by society as just a stubborn behavioral quirk. But especially in infants and children, whose brain and bone development can be permanently stalled, the severe malnutrition carries lethal potential. We have to treat the medical reality, not just our societal assumption.
Which brings us to part 4, the crucial psychological distinction. Now we reach the absolute core of our explainer. This is the critical boundary line separating these two diagnoses.
If you take away just one thing from this explainer today, let it be this stark juxtaposition, known diagnostically as criterion C. Anorexia is rooted deeply in body image disturbance and an undue influence of weight on self-evaluation. ARFID, on the other hand, explicitly lacks any disturbance in body weight or shake experience. If a patient is restricting their food intake because they want to lose weight or are afraid of being fat, they absolutely cannot be diagnosed with ARFID. ARFID is a strict diagnosis of exclusion when it comes to body image. This distinction right here is the watershed moment that determines how we understand the patient's internal struggle.
To further show just how different the internal reality is, get this, individuals with ARFID have roughly 13.7 times higher odds of also having autism spectrum disorder. 13.7 times. Unlike anorexia, which is highly associated with perfectionism and obsessive-compulsive features, ARFID shares an incredible amount of overlap with neurodivergence. And why does this matter? Because that staggering odds ratio tells us that diagnosing ARFID requires clinicians to look at a patient through a neurodevelopmental lens rather than purely a traditional psychiatric one. It represents a fundamental difference in how the brain processes sensory input, completely devoid of societal pressures regarding weight.
Finally, part 5, tailoring the treatment. Because the psychological drivers are complete opposites, the ways we approach treating these two conditions must also be fundamentally different.
While both share the vital goal of nutritional rehabilitation, you simply cannot treat a sensory issue or a choking phobia with therapies designed to correct body image distortion. It just doesn't work. For anorexia, therapies focus heavily on addressing the intense fear of weight gain and normalizing eating patterns. But for ARFID, we use adapted versions like CBT-AFRD. This is a modular, exposure-based treatment. If the patient is terrified of vomiting, for example, therapy revolves around slowly exposing them to that specific fear. Interestingly, patients with AFID often require a higher likelihood of enteral nutrition. That essentially means relying on tube feeding to bypass the physical or psychological bottleneck entirely, ensuring they survive while the long-term specialized exposure therapy takes place. So, I'll leave you with this thought to ponder today. If a profound physical crisis can stem from such wildly different internal worlds, how many other conditions are we misjudging simply by looking at the surface? Understanding this crucial distinction between ARFID and anorexia nervosa not only improves targeted medical care, but completely reshapes how we view the complexities of the human mind. They may look identical on a medical chart detailing bradycardia or malnutrition, but one is a battle with body image, while the other is a battle with the sensory experience of food itself. Thank you for joining me on this explainer. Until next time, keep asking questions and keep looking beneath the surface.